Hello everyone. In this lecture, we will discuss ECG features of some electrolyte disturbances. So first is hypercalcemia. The main ECG abnormality seen in hypercalcemia is shortening of the QT interval. In severe hypercalcemia, Osborn waves or J waves may be seen. Ventricular irritability and ventricular fibrillation causing cardiac arrest has also been reported with extreme hypercalcemia. So this is an ECG of hypercalcemia where you can see that the QT interval is very short. Here, here, here. Normally the QT interval is either 350 to 450 milliseconds, or in simple words you can remember that it is 9 to 11 small boxes. But if you see in this ECG, the T wave is merged with the QRS complex. You can't even see ST segment in between. So it is literally 5 to 6 small boxes only. So this is an ECG of hypercalcemia. Another feature of hypercalcemia is Osborn waves. Osborn waves are basically a positive deflection which you can see at the end of QRS complex in severe hypercalcemia. The Osborn wave is also called J wave. J wave, why? Because it occurs at J point. J point is the junction between the QRS complex and ST segment. So whenever you see a positive deflection at the J point, it is J wave or Osborn wave, and it is usually most prominent in the precordial leads. Hypocalcemia does the opposite of hypercalcemia. Instead of QT interval shortening, it causes QT interval prolongation, primarily by prolonging the ST segment. The T wave is typically left unchanged, and dysrhythmias may occur like torsade de Pont. In this ECG, if you notice that the ST segments are quite prolonged, due to which the QT interval is prolonged. Normally, as you mentioned, that the QT interval should be between 9 to 11 small boxes. And if you count in this ECG, then there are almost 13 to 14 small boxes. So hypocalcemia causes QT interval prolongation. In summary, this is a normal heartbeat. Just look at the ST segment. Now in hypercalcemia, look at the size of the ST segment. It has become shorter and the T wave has become closer to the QRS complex. So the QT interval has shortened. In hypocalcemia, however, the ST segment has become very long, due to which the QT interval has also prolonged. ECG manifestations in hyperkalemia are peak T waves or prolonged PR segment. Sometimes P waves are absent. The QRS complexes might be bizarre and wide, and you can also see a sine wave pattern. Here is an example of tall, symmetrical peak T waves in hyperkalemia. The T waves are even taller than the QRS complexes. This is the second example. If you can appreciate that the QRS complexes are bizarre and very wide, and the PR segment is prolonged. Normally, the PR segment should be between 3 to 5 small boxes, but if we count here, it is almost 7 boxes. In hypokalemia, the amplitude and width of P wave is increased instead of T wave. In fact, the T wave is flattened or inverted in hypokalemia rather than being tall and peaked. The PR interval is prolonged in both hyper and hypokalemia. Also in hypokalemia, you will notice ST depression, prominent U waves, and the QT interval will be prolonged because the T waves and U waves are fused together. So we call it QU interval instead. What do I mean by that? Like, see, here's the close-up. So this is the T wave, right, which is inverted, and here's the U wave. Now the T wave and U wave, they're merged together. So what we call this, that starting from the Q wave up till the end of U wave is the QU interval, which is very prolonged. As I mentioned before as well, that it should be 9 to 11 small boxes. And if you count here, it is almost 16 small boxes. Now look at this ECG. I'll zoom in for you guys. Here. So see, the ST segment is depressed. T wave is inverted, then U wave is very prominent, and QT interval or QU interval is prolonged. Next is hypomagnesemia. The primary ECG abnormality seen in hypomagnesemia is also a prolonged QT interval. For example, in this ECG, the QT interval is 510 milliseconds. Normal is between 350 to 450 milliseconds. Finally, I wanted to talk about hypothermia in this lecture as well. In hypothermia, you will see bradyarrhythmias, Osborn waves or J waves, which we mentioned in hypercalcemia. The PR interval, QRS complex, and QT interval, they all are prolonged. You will see shivering artifact because in hypothermia, the patient is shivering. You can find ventricular ectopics, and the patient can go into cardiac arrest due to ventricular tachycardia, ventricular fibrillation, or asystole. Here's an example of an ECG in a patient due to hypothermia. You can clearly see that the patient has severe bradycardia. However, the bradycardia is sinus in this ECG. Patients in hypothermia can manifest with a variety of bradyarrhythmias. So they can present with the sinus bradycardia or atrial fibrillation with slow ventricular response, slow junctional rhythms, or even heart blocks. This is another example. Again, the patient is a bradycardic. The patient has this shivering artifact. Also, you can see Osborn waves. You see this positive deflection at the end of QRS complex, the Osborn wave or J wave. Okay, so that's it for today. But before I finish, I want you to remember one thing, that all hypos, that is hypocalcemia, hypokalemia, hypomagnesemia, and hypothermia, they all cause prolonged QT interval. Take care. God bless you all.